Good morning, everyone, and welcome to today's Readmissions Refuel Phase 2 webinar. Thank you so much for joining us. We have just a couple of housekeeping items we want to review with you quickly before we dive into today's session. Just a reminder, if you haven't already, please do mute your phone lines. Try to avoid placing the call on hold. And we really want to encourage you to use the chat function throughout today's session to engage with us, share your thoughts, questions. We'll be moderating the chat throughout today's session and then also at the end of the session. A reminder that today's session will be recorded and transcribed. We'll post these on Innovation in the next few days when the transcription returns so that you can access it and share it with other members of your team. All of our project documents, our presentations, and our recordings are going to be archived in Innovation under the Resources Library tab found in the Refuel folder. Okay, so here is today's agenda. We want to welcome you and go over some brief announcements. Then we're going to move into really understanding the root causes of readmissions and overviewing some strategies for doing that. We're going to talk about identifying readmission risk and post-discharge needs, and then using that information to develop some enhanced services that help address those needs. We want to encourage you to use all this information to plan as you make some improvements in your facility. We'll wrap up with a Q&A and then finally go over some next steps before we adjourn. Okay, so I do have a quick poll I want to drop in. Give me just a moment while I deploy that. Oh, it looks like the polling is going to be inactive. What I want you to do then is to turn to the chat function, and it can be found under your toolbar under More, and type into the chat. If you happen to have members of your team listening along with you today, would you just type into the chat whether you have 2, 3, 4, 5, however many people you have listening in with you today, and we'll give you just a minute to do that. Awesome, thank you for doing that. We see those coming in, great. Give you just another minute or two to find that chat and type in how many people you have listening with you today. So while you're finishing that up, I want to really welcome you all and thank you so much for joining us. My name is Kate Carpenter, and I serve as the Quality Improvement Advisor for the Compass HIN. I'm the project lead for the Readmissions Refuel project. And it is my privilege to introduce our advisor on this project, Dr. Amy Boutwell. She is the president of Collaborative Healthcare Strategies, a national thought leadership, strategic, and technical advisory firm specializing in strategies to achieve high-value care, improved whole person care across settings and over time, and focus primarily on reducing acute care utilization among the highest risk populations. Dr. Boutwell is a nationally recognized expert in the field of reducing readmissions and improving care for high utilizers, advising statewide initiatives to reduce readmission and improve care in several states and nationally through the HINs. She co-developed the ARC Hospital Guide to Designing and Delivering Whole Person Transitional Care called the Aspire Guide, which is the foundation for the Readmissions Refuel initiative. Dr. Boutwell is a graduate of Stanford University, Brown University School of Medicine, and the Harvard Kennedy School of Government, where she received the Robert F. Kennedy Award for Excellence in Public Service. She trained in internal medicine at Massachusetts General Hospital and practices hospital medicine. We're really honored that to have her presenting with us in all 3 Refuel project webinars, and really grateful for her willingness to partner with the Compass HIN on this work. Before I hand it over to Dr. Boutwell today, I do want to make a few brief announcements and remarks as we kick off phase 2 of our project work today. As most of you know, the Refuel project was designed to help support your efforts in achieving the Partnership for Patients goal to reduce readmissions by 12%. Our vision was really to refuel your tanks for this work and build you up with new energy and some fresh ideas, robust resources that could help you drive change. In phase 1, we refueled by reinvigorating our readmissions teams and engaging our leadership then we use some strong data and fresh eyes to help inform your goals and your strategies as we move forward throughout the rest of this project. We felt really fortunate that you reached out to us to partner with you in the work. We fielded over 20 coaching sessions during phase 1. And through that opportunity, really wanted to share with you 2 things really I took from those coaching sessions. Number 1 really is that you guys are really doing this work. It's hard, it's exciting, it's frustrating, it's so many things at times, but I really saw you guys digging your teeth into this and working hard to be successful. And I am personally just so grateful and appreciative of your efforts. And lastly, number 2, that really at the end of the day, this isn't really about all the anecdotal things that we're talking about or choosing one data point over another. It's really about the patient. It's really about all the patient stories you guys told me as we met and we looked at your data together. It's those stories, it's those patients that really should fuel our work and our commitments to this, to reducing readmissions. So I could almost get choked up about it, actually. You guys I learned so much from you. So to wrap up, thank you to this cohort for your incredible work so far. You really refueled my connection to this work, and I hope we've done the same for you. So a couple really brief announcements. I just want to remind you to be using your participant guide to help guide you through your to-do items during each phase, and use the resource links as a resource. We're going to be referencing several of those today. Use your project guide to help give you easy access to those resources. Make sure scheduling is a hard thing. That can be a challenge, and so be proactive. Make sure your team is registered for the phase 3 webinar on April 11th. Please do use the coaching we're going to be offering in phase 2. We have Sarah Pavelka, our performance excellence resource and faculty member, and then obviously all of our quality team here at IHC who is ready to assist you with your performance improvement work in phase 2. So please do utilize that. A reminder, there will be a phase 2 survey that's sent out, a Survey Monkey. It'll go out the end of March and it'll be due back the first week of April. Okay, so with that, without further ado, we've got a really full session for you today. So I'm going to hand it off to Dr. Boutwell at this point for the phase 2 project content.
Okay, thanks, Kate. And, really thank you for reminding us that what we are doing here is refueling our tank. And I can't think of a more invigorating way to start this webinar than to hear how much you've learned and you appreciate the work that's going on in the hospitals in this collaborative. And it really, I felt the energy, and I hope you all do too. So with that, we'll turn to our phase 2 content. So today is really about designing interventions to address the root causes of readmissions. As Kate reminded us, we had 4, if you will, refueling stops in our phase 1, which was about looking at the data, use data to inform who are your high-risk patients, take an inventory of your existing efforts within your hospital, as well as the resources out into the community, and engage and refresh, build and expand your hospital-based and cross-continuum team. So next slide. We had the survey that many of you filled out, which we really appreciate. And Kate and I dug into that survey, and as you know, to support what Kate just said, what an incredible amount of progress and engagement that we see. So with regard to making sure that we have that executive sponsor commitment, 96% are a yes on that. 96% refreshed their team. About almost 99% refreshed their data. A majority did within this first month, and a third of you are still in progress with that. But I mean to take up the call to really be data informed and take a new fresh eye look at your data is so encouraging, and it's such a strong step in the right direction. 70% reported that you have a specific readmission reduction goal. What are you doing for which patients? How much? What is your targeted magnitude of reduction over how much time? And then 3/4 of you have that identified target population. So this is a really impressive place to be. And again, even if you already had these elements in place, the fact that you took a look at it and recommitted to yourself that, you know, yes, you want to keep going with the target pop or the goal you have, or refresh and update. Either way, the vast majority of you have completed that in this first month of work, and that's really great. Next slide. A couple things that we learned from the survey we just kind of harvested here on the slide the target populations that you reported to us you're focusing on. And of course, this is a compilation across the collaborative, but we've got some teams that are really taking a look at age as a factor. And so one team is looking at age over 80, another team is looking at age over 66. Interestingly, another team is looking at the younger adults in the 51 to 65 category, which is a very great new group to look at. And another group defines their target population as a combination of age plus a primary diagnosis. So moving to the next kind of way of thinking about target populations that are here in the collaborative, of course, we've got kind of the Medicare heart failure COPD focus. We've got teams that are focusing on heart failure in general, or pneumonia plus COPD. One team has a combination of COPD patients with sepsis, and another team is focusing on sepsis. And so again, we see these signals coming out of our first phase 1 webinar, where it seems like you have taken a fresh look and you're looking at some new and expanded target populations and identifying those groups who really are at high risk. We've got a target population, which are those Medicare heart failure patients discharged to home. So kind of thinking about a target population based on discharge to physician and what those patients might need once they go home. Many reported looking at all patients or all readmissions, all acute and skilled, recognizing that in your critical access hospitals, you've got a combination of those types of swing beds. One team is looking at same cause readmissions. Here's this fifth bullet point was very specific, and I shared it because I just loved what that meant to me, which is you have thought this through. Whatever this means to you, you've clearly thought it through. So one team is targeting patients with J codes, with patients who have been readmitted within 15 days, and patients over the age of 65. So what I love about that is that clearly this reflects a team that has sliced and diced their data and said, hey, we want to look at this group and that group and another group. And that is a very fine way of putting together a few groups of patients who, in your data, according to what you know about your patients, are at the highest risk of readmission at your facility. And then finally, we've got a team who is taking a look at those high utilizing patients. And so again, a wide variety of ways of focusing this work. And many of the signals here are that you are taking a data informed and refreshed update to your target population. Next slide. You reported back to us some successes and challenges from phase 1, and these are just absolutely representative of the work that we do in readmissions. And so some of the successes, we were really pleased to see that, taking a deep dive into the data, getting some insight from your data. We heard that some of your docs really responded to data. They wanted more, which is a blessing. We heard that you were, able to really engage your team and take this opportunity as a refuel and a refresh to engage a team, find time to meet and discuss, which is a challenge for everyone, but to dedicate that time to act. One member reported back to us, we actually got to sit down and discuss readmissions, and that's really the secret, is getting getting our team together to really think and put our heads together. Another team was able in this first month to engage a new partner on their team, and this was a partner from long-term care, which is fantastic to see. We love to see those teams growing and broadening across the continuum. Another couple teams reported that the readmission interview and doing a root cause analysis on every readmission has been a good success for them in phase 1, and that's in fact what we'll dive into a little bit more today. So we're really glad that you're kind of working ahead of the game, which is fantastic. And finally, one team during their phase 1 work relaunched their care transitions program, again, which is great. A lot of good work in readmissions. It comes and it goes. And I was in a meeting just yesterday where, you know, we were saying, if you don't tend this work and manage it actively and support it, then it does tend to fizzle out. And so I think the success point that one collaborative team member noted for us, that, hey, we had to relaunch something that used to be in place, but it kind of fizzled. That is really real and wonderful success here in the first phase. For as many successes as there were as many challenges, which is not surprising. Data, time to run data, trying to figure out why a report looks different from another, you know, is a point of some challenge. Again, that's really, I hope you know, that's what Kate and the team are here for. And so if we do know that there are some members of the collaborative who are, you know, getting used to the measurement specifics. Why would one, you know, report from CMS differ from a report from the Compass HIN? These are important things for you to ask about if you don't know, because there are very clear explanations, and it just probably takes a phone call to work it out. Another challenge, which is you know, one that I think Kate really gave us some good advice on already, is time. And we, you know, in order to make progress, we need to make the time to meet together. And so if there's one thing that you might take even right now as a to-do, is ask yourself, have you put on your readmission team's calendars, have you made standing weekly meetings? And I do say weekly, standing weekly meetings for your readmission team. Maybe not everyone can make it every week. Obviously, clinical responsibilities and patient emergencies will get in the way of one person or another, but if you make a standing meeting time, then more often than not, you'll be able to make a little bit more progress than if you're always kind of trying to schedule only one week in advance. Turnover in leadership, I'll tell you, that is a universal challenge. And so, you know, one thing that I've learned is, you know, all of the you know, it seems like the great staff get promoted into great managers, the great managers get promoted into other leadership roles, and the great leaders tend to move on to other opportunities. I mean, turnover is just such a challenge in hospitals and in quality improvement that I think, again, that's why I would say to always strengthen your team and look at your team and think about building that internal capacity that can withstand the expected turnover, because there will always be turnover. And so I just wanted to share that really resonated with me as a challenge that we all deal with. Gosh, season and the snow don't help either. And so recognizing it, that hoping that maybe we're going to have a turn here in the next couple months so that you don't have to be so burdened with those basic challenges. And then finally, moving into some of the topics of today, some teams reported, hey, you know, we're still struggling to define that target population, to decide where to focus, and making change is really hard. And, you know, absolutely agree to that. And that's why we're going to spend some time today talking about some ideas that hopefully will move you forward. Next slide. So today what we're going to do is we're going to cover 4 more refueling stops. So you can see that over the course of our Readmission Refuel Collaborative, you're going to end up with a series of about 10 or 12 specific action steps that you can always come back to. You'll make some progress and you'll skip over others. We want you to work through all 4 the best you can, but I just wanted to point out that, you've already been through 4 recommended actions, and here we're going to introduce today 4 more for the next phase of the work. So the 4 new refueling stops for today and this phase 2 are: number 1, really work to understand those root causes of readmissions. One thing that we do is we talk about diseases, or we talk about self-management, or we talk about appointments, or we talk about teach-back, and those are not actually root causes of readmissions. And so I want you to really hang in there with me while we describe understanding really why patients come back, and that there's power in understanding the human element as to why somebody came back. Number 2 is we want to talk today about identifying readmission risks and post-discharge needs. Now, this is not very different from what we all do in the hospital every single day, right? We're assessing people every day. We have physician assessments, we have nursing assessments, we have case manager assessments, we have social work assessments. We're assessing constantly, but we're going to bring a little bit of strategy and depth, I think, to looking at our patients with regard to asking ourselves, what places this patient at risk of readmission, and what are their post-discharge needs? And we have some tools for your consideration that you may find helpful to work with and test out. Number 3, once we understand root causes of readmissions, and once we understand what the readmission risk factors and post-discharge needs are, then what are we going to do about it? Now, this is a section where I really want to emphasize the importance of connecting our interventions or our services to the root causes. Again, a lot of our work, I'll say, in the early part of readmission reduction work is we're just kind of throwing appointments and phone calls, and we're just doing things, all of which are good and fine ideas. But what I want to emphasize today is, are we really matching the services that we're delivering to the root causes of the readmissions? And that's an ongoing question to ask, but we'll explore that today. And then finally, we've got to move out of analysis and problem definition and move into today's the day we're going to move into action. And so we want to support you in planning and making those improvements, breaking it down into small, actionable, feasible steps on a day-to-day and week-by-week basis that will allow you to learn and go through these 4 refueling stops over and over and over again until you feel like you have really put your finger on something that is working and worth scaling up. Next slide. So let's start out here with understanding the root causes of readmissions. Next slide. So the best data analysis, as I hope you appreciated, I know you did from phase 1, we really need to know our data, and that is essential tool number 1. I would give it co-equal weight to say the best data is not enough to have a strong program. We also need to match that with a very good understanding of the root causes of readmissions. And so the way I think about identifying root causes of readmissions is really the story behind the chief complaint. And here are 3 of my readmitted patients, and I'll just kind of read you the one-liners and ask yourself, would you have considered this person at high risk of readmission, and what do you hypothesize would be the root cause of the readmission? So the first gentleman was an 86-year-old gentleman. He had unfortunately just been diagnosed cancer, and his primary care doctor knew about it. He had met with the oncologist. He had been fully worked up. Sadly, he had metastatic disease to his bones. He and his wife and his family knew about his condition, and he was started on pain medicine for his bony metastatic pain, of course. Well, so he first came to the hospital. After all this workup, he came to the hospital about 8 days after starting the oxycodone for constipation, which was causing him abdominal pain. Well, his big concern was, is my abdominal pain from the cancer, right? Because he had just been diagnosed with cancer and he didn't really, know how his body was going to be feeling. So he had a great question. It turns out that he came to the emergency room and the emergency room nurses took care of that constipation problem, lickety split. And really it was kind of problem solved at that point. So the first element of this story is he was admitted kind of just in case he needed further workup. Whereas if the ED had called his PCP or his oncologist, both doctors would have said, he's been fully worked up. Thank you for fixing his constipation, and we can take it from here. So this readmission interview story, the first thing I want to share with you is the best way to avoid a readmission is to avoid an avoidable admission in the first place. Okay, so that's kind of insight number one. So then he was sent upstairs and discharged the next day. He started on a bowel regimen and he got home and there he met his daughter who had driven up from New Jersey. She had dropped the kids at a neighbor, called in sick to work. She was worried sick. Now her dad with cancer's in the hospital. What in the world is going on? And she said, Dad, why are you home so soon? How's your pain? And he, as you'll imagine your 86-year-old dad or grandfather would do, he kind of goes into a long soliloquy about the nature of his aches and his pains and how things just don't feel right. And she absolutely was livid. She thought to herself, how could those people at that hospital send my father home in pain? Human reaction, right? So she plopped him in the car and drove him right back to my emergency room, and that's where I met him. I met him on the readmission, and I looked at him, I obviously gathered the story that I'm telling you now as the admitting doctor. And once I figured out this story and what was going on, I looked at him and he looked at me and I kind of whispered to him, I said, I don't really think you need to be here. And he said, yeah, me neither. But he kind of cocked his head over to the side in the direction of his daughter. And he said, but she's worried, so it's okay. I'm fine to go upstairs, right? So up he goes. Up he goes. Why? Because what we really needed to do was have a family meeting. And that's what we did the next day. However, in the course of this very human story, which happens to be related to cancer, no true medical intervention was needed, but what was needed was a family meeting. And that wasn't likely to happen in the emergency room at 11 p.m. at night, was it? So this is the value of what you can get by getting the story behind the chief complaint. If we were just doing a chart review, you would see an older man, cancer, abdominal pain, returning for abdominal pain. You might even think this is not avoidable. That is why we have to get to the bedside, as every clinician does, right? I interview every patient by definition. That's my job as the admitting doctor. Your job as the bedside nurse is to admit and intake your patient. Your job as the case manager is to have an intake interview with the patient. We're all interviewing people all the time. So my message is this isn't different from our workflow. It's just taking a different angle to make sure that we're listening to what happened between the point of discharge and the point of coming back that led the patient to come back. It's very rarely an actual medical acute change in status. Okay, so next quick story, 45-year-old woman, HIV, hospitalized for pneumonia. Unfortunately, fortunately, she had had HIV for a long time, 2 decades, and had never needed any treatment. She was one of those lucky ones. And unfortunately, when she came down with pneumonia, she also needed to go on those HIV medications. And so she was started on HIV medications and antibiotics. And this was a 45-year-old woman who had never been taking any medications. And she was discharged to home and told to follow up with her primary care and HIV doctor. Well, guess what? She didn't have one. She didn't have one of either. She, as far as she was concerned, had kind of been lucky in living outside of, regular medical appointments for years and years and years. Here's the thing, is that although she's a 45-year-old woman, and to look at her, you would think that she could find a doctor Well, she lived with her mother-in-law and her stepdaughter, and neither of whom knew her HIV status. And she wasn't about to start making phone calls in her house to try to find an HIV doctor. It was too much to ask. And so it turns out that she was taking her medications as prescribed. She didn't miss any doses, but 8 days passed and she still had a lingering cough. Well, this is a fairly with it woman who is telling herself, well, I just got diagnosed with pneumonia and AIDS, and I just got out of the hospital a week ago. I'm still coughing. She had a totally normal question. Should I still be coughing? Is this okay? It's actually a nurse hotline question, isn't it? It's an ambulatory nurse triage question. It's for sure an ambulatory office visit. But because she didn't have anyone to ask that question to, she came back to the emergency room. She had no fever. She had no other complaints. She just had that lingering cough, as we all tend to do after pneumonia. But boom, up she goes. Because she was labeled with HIV, pneumonia, she was back within 8 days. Up she goes for a readmission. And it was only the next day when we figured out there was really nothing wrong with her. She just had this question. And we advised her, yeah, you might have a cough for 10 to 14 days. That's to be expected, no problem. And off she went back home again, this time with a care team in place. So again, ask yourself, would we have recognized that this is a woman who did not have a primary care doctor? She did not have a specialist. She had never taken meds, and now we're discharging her on 5 meds. When we put the story together that way, everyone on this phone call can clearly see this was a readmission risk. But at the moment in time, we were looking at a young woman who was being discharged, and we assumed that she would be able to navigate the system herself. The final gentleman was an 61-year-old man who had been in the hospital 8 times this year for shortness of breath, and he's coming in every 10 days, and he always has like a 4 or 5 day length of stay. He is almost living in the hospital. It's all shortness of breath, coming in for shortness of breath. The issue is that he has heart failure, COPD, morbid obesity, obstructive sleep apnea. He doesn't use BiPAP or his he doesn't engage in his exercise regimen, and he still smokes, and he doesn't take his medications, right? So we all know this type of a person, and he is in and out of the hospital. Well, when I met him for the first time, I looked at all the discharge summaries, and they all said the same thing. Follow up with your PCP and stop smoking, and some combination of get a sleep study or pulmonary function tests. Now, we had, at my hospital, we had replicated that as the assessment and discharge plan 8 times in a row, never asking ourselves, is this an effective plan? Do we think there's any chance this is going to work? And so what I want to convey in this situation is the value of looking at the pattern. What have we tried to do 8 times already? And perhaps by looking at the person and their repeated pattern, we will save ourselves from making the same mistake the 9th time, telling him to follow up with his PCP. P.S. He hasn't been to an outpatient ambulatory appointment in 3 years. Why is he going to go, why is he going to follow our instructions the 9th time unless we do something very different to help ensure that, he gets there successfully. Next slide. So what we really want to do is we want to make sure that we are listening to these human elements that lead to readmissions. I'm going to break down a readmission kind of root cause analysis for you here in 2 or 3 slides. This is a patient who, again, she probably wouldn't have been identified as your typical kind of Medicare heart failure or COPD patient. She is a 77-year-old woman. She has end-stage renal disease, hypertension, heart failure, and osteoporosis. Her first admission was to get a tunneled catheter placed so she could start dialysis. Okay, unfortunately, during that first hospitalization, she developed line sepsis and went to the intensive care unit. So, of course, she was critically ill. All of her home medications were put on hold. She was on, the medications in the intensive care unit. Thankfully, she stabilized. But as you imagine, she was, pumped full of fluids and different types of medications. She came back to us on the floor, and she was doing okay. Well, in fact, she thought she was doing so well that on day 2 out of the ICU, she had kind of done her hair up, put her lipstick on, and had her handbag on the meal tray, right? Kind of declaring herself good and ready to get out of here. And because she was married, she was highly educated, she has a PCP, a cardiologist, and nephrologist, she appears to not have any readmission risks. So she was discharged to home, and she wanted to go home. I met her 8 days later in the emergency room when her lungs were full up with fluid up to her clavicles, and she was extremely short of breath. At that point, she, of course, needed to come back in. She was scared. This is the power of getting to the bedside. She was scared. She was fearful. She honestly worried that this was the beginning of the end for her. It was profound, and I'll never forget her. She thought everything was going wrong. And up until this point in her life, active tennis player, going to lunch with her friends, no problems. Next slide. So of course, that this is the moment when you engage in the story of the readmission. And I just said, tell me about what happened between the day you were first discharged and today. Let's just go day by day. How did you feel when you first went home? And at that point, I felt fine. I was glad to be going home. I wanted to go home. I said, well, then how'd you feel the next couple of days? Well, day 2, 3, and 4, I took to bed. I felt like I had been hit by a Mack truck, and I'd been through an ordeal, so I let myself just rest. On day 5, she tried to resume her normal activity, do a few errands, and she was wiped out. And by day 6, she noted that she was really getting easily winded just walking around the house. Day 7, she felt so unwell, ding, 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 that she didn't go to her follow-up appointment, is how badly she felt. Aha. And then by day 8, she was in extremis and she had to come back in. So when I said, well, let's review your medications, I come to find out at that point, and she hadn't even told me up until then, that upon discharge, all of her home medications were still held. And she had not been instructed to resume any of her antihypertensives or her diuretics on discharge, and so she hadn't been taking them. And she wanted to wait to see her own doctor to see what her doctor wanted to advise her, right? So here we go. There's the root, there's the root cause. Next slide. So a couple lessons from here is that a lot of people, a lot of us think, well, gosh, readmissions happen because people are so sick and they're rushed out the door. I'm not sure this lady was rushed out the door, and she certainly didn't feel like she was, for what it's worth. The issue was clearly around follow-up, symptomatic follow-up, as well as instructions regarding her medications. And there are so many ways that during those 8 days, someone could have, the system could have found her and discovered any of these issues and intervened before she needed to come back to me on day 8. We could have been in contact with her either with a phone call or a home visit or an earlier appointment. We could have checked in on her symptoms, feeling winded and being hit by a Mack truck and not being able to resume activities. If we had known that she missed her appointment and had called and reached out to her, we could have gotten her back into her PCP before she needed to return to the emergency room. And of course, if we had done any follow-up post-discharge on med-rec, we would have caught this mistake as well. Next slide. So I hope you can see how getting to the bedside and having these discussions, it is part of our work, and also it's high value. What you can see here is just a little, I wrote up this little slide just to kind of script out the way I typically introduce the discussion and have kind of an open-ended just prompt. Tell me about what happened between the day you were discharged and the time you came back, and you just prompt for some, prompt the patient to keep going with their story. Sometimes people think that the readmission interview needs to be done just with the patients themselves, and people will tell me, oh, the patient was too sick, or they were demented, or they couldn't talk, or they didn't want to talk. Well, then perfectly fine. As we do in all of clinical care, we move on to the caregiver, we call the PCP, we call the home health nurse, we get collateral information to help fill in the picture. So when we say the interview, it's really the information about what happened between the discharge and the readmission from any informed source. Next slide. So in your toolkit, in your resource packet, you have the readmission review tool. And one thing that we know is that we all do our work in different ways. And so the script I just showed you, the readmission tool, these are really meant to be prompts and guides as to what we're looking for, what you're looking for in a conversation with your patients. I really recommend that you all commit to doing at least 5 of these. When you have a name and a face and a story in your own personal experience, it's so powerful to help inform your readmission work that regardless of if you're an administrator or a clinician or a quality improvement professional, whatever role you have, I really do recommend that you have this type of a discussion with one of your readmitted patients. So we're really lucky now. I'm just going to pause on this slide, and I'm going to invite Sharon Campbell, who's the Director of Nursing from Knoxville Hospital. Sharon was so brave and wonderful and proactive to get a little coaching on this readmission interview idea and to actually get to the bedside to talk to a couple of her readmitted patients over the past month or so. Sharon, are you there?
Yes, good morning.
Hi, good morning. Thanks so much for joining us. So Sharon, if you would, could you tell us a little bit about the patient that you were able to interview?
Yes, we had a patient from a nursing home who had been with us for a little while. She had an exacerbation of COPD, and she also had a history of DVT, so she was being treated with Coumadin. She recovered from her COPD experience there, went home on the Coumadin. While she was at the hospital, we had a little bit of trouble, getting the right dose of Coumadin, but we thought we got the right one. So anyway, she went back to the nursing home. The doctor went to the nursing home and visited her there about 2 days later, so 2 days after her discharge, and had some more labs drawn and found out that her INR was a little low, so her Coumadin was subtherapeutic. He adjusted the dose of her Coumadin and then ordered another INR to be checked 2 weeks later. So 2 weeks later, they check it, and the INR is 15. And so our patient came back as a readmission because of that high INR.
And tell us a little bit, Sharon, what was the patient's experience of this? What was her understanding about why she needed to come back, and what was her kind of, I guess, her experience needing to come back for this high lab value?
She was familiar with her Coumadin and needed to have INR checks. So, when she found out her INR was 15 and they told her she had to go to the hospital, she was okay with that. It didn't really alarm her too much. Her main concern was that the room she was staying in at the nursing home was cold. So it didn't really alarm her all that much. It was actually kind of cute, but also.
Right. Yeah, it's a great insight because, it's helpful, I think, to remember that, I had one patient who was scared and fearful and thought the sky was falling down when she got readmitted. And then here's your patient who basically says, well, this is just the way the cookie crumbles, and here I am. And by the way, I'm going to tell you about my chilly room at the nursing home. So we kind of get a little insight into her experience and her priorities, which are to be comfortable. So what do you think, if you had to say, what do you think the root cause of the readmission was in this case? And have you thought about some ideas that we could avoid this type of thing in the future?
Yeah, well, the root cause was that the INR didn't get rechecked for 2 weeks after a Coumadin dose change. Looking back at it, our transition care team could have followed up maybe a little bit more to say, hey, when is your next INR going to be checked? Also working with the nursing home to make sure that they know, when the next INR should be checked as well. In the meantime, the doctor actually did visit with the patient probably about a week into it and did some other labs too, but that INR still didn't get checked at that time. So follow up, will be done with the physician as well.
That's great. And so again, at that point she had the high INR, but just because she needed to come back at that point, as Sharon is articulating, there were 2 or 3 ways that we could have potentially avoided that readmission with a earlier recheck and a little closer follow-up on that lab. So that's great. So Sharon, now that you've done a couple of these, how much do you find value in taking this approach to understanding readmissions, and what would you say to the others on the line about kind of the readmission interview approach?
I think it's great. We have a tool that we use, but with working with you, we made it more of a conversation. So we still use the tool, so we make sure all the same questions get answered, but when we go in and visit with the patients, we make it just kind of like a casual conversation going on in there. And then going forward, I think just involving more of the other, like the nursing homes or the home care or whatever, might be involved in that situation is definitely what we're going to make sure we get into the conversation as well.
That's great. That's great. Anything else you would add? Thank you so much, Sharon, for sharing your experience. I think it's really important to emphasize what you just said, which is, take a tool, modify it, work with it. The idea is really to make it work for you, so that you get value out of the discussion. Because bottom line, we want the purpose of doing this is to strengthen your readmission work and the insights that you can get from having these types of conversations. Anything you'd like to add, Sharon, before we move on?
No, I don't think so. All this information has been really helpful, so thanks a lot for your help on this.
Oh, that's great. Well, thanks so much for joining us. I really appreciate it. Kate, I'm just going to let you know that somehow my connection to the Zoom was just lost. So I'm going to just click on the link again and try to get back on, and I hope that doesn't mess anything up.
Sounds good.
So, okay. Sorry, everybody. There we go. There we are. Okay, so next slide, Kate. Oh, do you hear me? Join audio.
Got it. We're on slide 21. Hang tight, everyone. I think Dr. Boutwell is trying to reconnect with us. We see you back, Dr. Boutwell. Whenever you're ready, we are on slide 21 and ready to move forward.
Kate, can you hear me?
I can hear you now. Go ahead.
Oh, wonderful. Okay, I'm so sorry, everybody. Okay, so next section, we're going to talk a little bit about identifying readmission risks and post-discharge needs for your patients in general. Next slide. So based on your readmission interviews, I want, and I know you'll do some in phase 2. So as you move into testing out this approach on identifying root causes and really connecting with the human story of your patients who have been readmitted, I would encourage you to collect a list of the factors and the issues, the barriers that your patients face that place your patients at risk of readmission. So in our couple examples here, an active medication titration, whether that's Lasix, whether that's Coumadin, whether that's a new medication, we can all identify new high-risk medications being started or actively titrated need to be followed very closely. So Sharon's example would have been a great root cause to put on your worry list. So too, a couple of my examples, would be, a patient who's being discharged for sepsis. As you know from your data, sepsis is a leading cause of readmission that many of us haven't been focused on yet, but some of you are focusing on now. And so, sepsis really, and the physiologic instability of sepsis, means that people need a lot closer follow-up after the hospital stay. So that's how you can use your root causes to start preparing yourself moving forward to the next patient you meet, to listen for these root causes in the next patient that you meet so that you can better serve and avoid that next readmission. Next slide. So here is, so as we move into risk assessment, what we're really looking for is just, again, an expansion on what I know we all kind of think we do every day, which is look for readmission risks and post-discharge needs. But this is a little bit broader than that. It's close, but it's just a little bit broader. Typically, we look for patients who are, quote, high risk of readmission, meaning they have some sort of trigger or risk score or risk group that they are in. Well, what we want to do when we're assessing all of our patients is ask ourselves, what are the clinical, behavioral, social, logistical needs that might place this person at risk of readmission, even though they're not a Medicare heart failure patient discharged to home or someone in a high-risk group that we have identified. So this is where we can improve standard care for all patients by really asking ourselves, not only is this patient at high risk of readmission, but even if they're not, what are the issues that might lead them to be at high risk of readmission or have post-discharge needs? And then the idea here is when we identify a readmission risk or a post-discharge need, we want to have a response system in place so that you and your case managers and your hospital floor teams have something to offer or connect the patient to if they are identified as being high risk or having post-discharge needs. So there are a couple tools that I'm going to orient you to, and you might decide to, take these back to your teams, and you might like parts of various tools. Again, the best thing about a tool is it's not a blank piece of paper, and each one of the 3 tools I'm about ready to show you have some really great strengths, and I would probably borrow and select from all 3 of them. So let me just orient you to a couple of these readmission risk and response tools. So I hope you are familiar with the Boost 8P tool. It's kind of a classic now in readmission work. This came from the Boost initiative many, many years ago now. It still holds up as a very nice tool. The way we would use this tool is the P's, the 8 P's, being problem medications, psychological issues, principal diagnosis, polypharmacy, etc., down the left-hand column. The way you use this tool is not as a risk score, but rather as a risk screen. So that means if I have 10 patients on my service, I'm going to ask myself for all 10 patients, which of my patients has any one of these P's, right? They've been here recently. They need palliative care. They lack good patient support in the home. They have poor health literacy. Oh my gosh, you know what the answer is it's almost all of them are going to have one or another of these P's. That's what distinguishes a risk score from a risk screen. Expect that many of your hospitalized patients are going to have one or more of these, quote, P's in their life. And so what we want to do in order to reduce their chance of readmission is we want to be able to say, okay, if we see polypharmacy, then what should we do? If we recognize that this patient has poor social support, then what should we do in response in order to mitigate this patient's risk of readmission? And so that's kind of how you use the left-hand column and the middle column. If you see a problem or a readmission risk in this case, then you want to address it some sort of, as you see up here in the header, risk-specific intervention, with some sort of intervention that you put into place. Next slide. So as I was charged after the boost was made, I was asked by the Agency for Healthcare Research and Quality to say, okay, the Boost 8P tool and many of our strategies are really applicable to the older adult population. How would you modify or expand on those tools in order to be more relevant to the younger adults or Medicaid population in general? And so kind of building on the identify and respond concept, and keeping our underserved Medicaid high-risk patients in mind, we kind of came up with a companion document that you might find some helpful elements on this document from the Aspire Guide. So over on the left-hand side, we kind of dig into the more nuanced social, behavioral, logistical factors that might lead someone to be readmitted. So it's not just does the patient have primary care, but do they go to primary care? Do they have work or family responsibilities that would pose barriers to daytime appointments? Are they in the habit of using the emergency room instead of primary care? So these are the questions that you can see as we adapt our work to focus on Medicaid or younger adults in addition to the Medicare population. We might want to ask or look for some of these issues. And then rather than have a risk-specific intervention like the Boost tool did, on the right-hand side, what we recommend is if you find any readmission risk or post-hospital need on the Boost tool or on the left-hand side of this Aspire tool, then obviously you're going to want to bring that to your interdisciplinary care planning. You're going to want to, mobilize whatever internal consults or bedside care that you can during the hospitalization. You're going to want to provide or link people directly to services and supports before they leave the hospital so that we don't leave it up to the patient to have to navigate and access care themselves. And so those are some responses that a robust transition of care team could take in response to any of the readmission risks or needs that we find in our patients. Next slide. And then the Readmission Refuel team has built on both of those to kind of bring it all together and then some with a needs, services, and tools set of recommendations here on this tool. And this is again in your resource guide. So just very briefly to orient you to this, again, you see on the left-hand side where we meet when we identify unmet patient needs, then in the middle column, what kind of enhanced services might a hospital readmission team and their partners be able to mobilize? And on the right-hand side are some really nice tools and resources that kind of substantiate that idea or give you more information about that idea. So this tool is very robust, and I'm not going to walk through all the elements of it, but rather wanted to make sure that we see it here together that you notice the different elements like behavioral health, literacy, and social needs that are highlighted on the gray bars, palliative care needs, PTOT, etc. So that, thank you, Kate, dietary needs, diagnosis-related needs, and discharge and transfer needs. So you can see there's about 4 pages here, and all of these tools are really meant to help your team say, look, when we find, we're going to, based on it, interviewing our own patients at our own hospital in our own community, we have learned that we have a need in palliative care, or we have learned that we have a need in transportation, or we have learned that we have some patients who just don't access primary care regularly. What should we do about those groups of patients? And all of these tools might be resources for you to dig in and take some brainstorming ideas from these tools. Next slide. So once we have, now that we understand root causes and we're looking for readmission and post-discharge needs among our hospitalized patients, we want to move into action and develop enhanced services to meet the needs of our high-risk patients. Next slide. So enhanced services is kind of a funny term, but it's I use the term because it's broad. It doesn't necessarily mean new staff. It could mean new staff. It can mean a variety of things. It basically, think about enhanced services as additional services and supports. They are not provided to all patients as routine care, but rather offered to subgroups of patients who are identified as one of your high risk of readmission patients. Oftentimes, enhanced services, in order to reduce readmission risk, are delivered during the hospitalization and after discharge, often for 30 days. And importantly, the services should be designed to meet the root causes and the needs of your specific target population. And I'll describe that in more detail here coming up. Next slide. So here's an example of an enhanced service using existing. So this comes from Ransom Memorial Hospital in Alabama, small critical access hospital as well. And their readmission team noticed, polypharmacy and affordability of medications was clearly a recurrent theme. And if you can believe it, it wasn't until 2017 when they had a bright idea about medications, and they kept trying to do med rec and kind of chip away at it that way, the way they had always been doing things, if you will. And finally, the readmission team engaged the pharmacy director at the hospital. And it turns out that he was more than willing to get to the bedside during his day. And they were a small hospital, so it was really just, 1 or 2 patients a day, or maybe not even. And it was not seen as a burden to him at all to add this into his day. In fact, he welcomed it. And so they were able to discover internally a resource that was more than willing to get on board with the team. And they would refer to the pharmacist whenever there was a patient on more than 20 meds, a new high-risk med, or a new diagnosis requiring intensive medication management, as you can see on the slide. And what he did was he obviously did a very thorough medication list review. He got to the bedside and chatted about adherence and affordability in a very detailed and person-centered way. He worked with the hospital docs and the community docs to optimize and streamline a regimen, then did education at the bedside, and he confirmed with the patient that they were able to actually obtain and purchase their medications once they left. And this was all stuff that he was willing to do. And so 2 secrets here. Number 1 is remember that there might be, especially in small hospitals, I know you all wear multiple hats, and I know that everybody's busy. But in this case, a pleasant surprise. They had never asked the hospital pharmacy director. It turns out he was willing to help. He found it interesting. He finds this work rewarding, and they've been able to sustain it. Next slide. Another example is also from well, this is actually from a medium-sized community hospital. They were really trying to do a better job for their COPD patients, as I know many of you are, and they had they finally modified, I would say, their readmission team to a COPD focus, because they saw in their data they were not making progress with their COPD readmissions. So just like you did in phase 1, they said, our data says we're not making progress with COPD readmissions. Their COPD readmission rate was actually in the 40s. So they clearly had a big problem. And so they refreshed and refueled their team, this time for the first time ever, bringing respiratory therapy onto the readmission team, and they never had before. Again, this is just last year in 2017. So putting their heads together, they realized very quickly, or the respiratory therapists realized very quickly, hey, they know all these patients. Why? Because they're spending 20, 30 minutes, 2-3 times a day at the bedside giving them nebs, right? And they get to chat, and they know them, and they hear, they see the family in the room, and it was just a real light bulb going off when they realized, wait, the respiratory therapists actually have a really good relationship with these COPD patients. And so they decided to, again, brainstorming together, the respiratory therapists and the pharmacists and the nurses said, well, why don't we use the bedside, nebulizer encounter to make sure that patients can demonstrate and teach back proper inhaler technique. The RTs would review the COPD zone self-management tool, again, just reinforcing what the nursing staff was doing, but it's again, repetition being the key here. They formed a strong relationship during the hospitalization, so actually the RTs ended up making the post-discharge follow-up phone calls for their COPD patients. Again, on a day-to-day basis, it ended up only being 1 or 2, sometimes 0 per day. So the RTs do not find it burdensome to incorporate this, into their daily work responsibilities. So it's working out really well for them as well. Next slide. So at least one of your teams said that you reinvigorated your care transitions work during phase 1. And care transitions is an example of an enhanced service. But the first 2 examples were really examples of an enhanced hospital-based service that then did some follow-up work via phone, right? So I just wanted to make it clear, there are many ways of delivering an enhanced service. And now we're going to talk briefly about transitional care. And so you can see by this little schematic that transitional care is meant to start in the hospital with the engagement discussion, and then it follows up in a timely manner within a couple days with the patient once they get to the next setting of care. An in-home assessment is usually the secret sauce to making these things effective, and then staying connected with the patient for about 30 days is the typical model. There are many variations on the theme, and I think that as long as you have these 4 components, an in-hospital engagement, timely post-hospital contact, an in-home component, and a 30-day time frame, usually the transitional care model is effective regardless of who does it and how many, what role type you specifically deploy to do this. Next slide. So I just want to do a quick counterpoint of 2 successful transitional care programs, very different model. They're both successful, but they're deployed to very different patient populations. And that's the key message of this slide. So in the first example, you have a nurse who is serving as a transitional care coach. I know many of you are familiar with the coaching model. And so they have a structured set of 4 encounters, as you can see on the slide. And the purpose of self-management coaching is, of course, the teach a man to fish model. You're going to teach the patient to identify their questions or needs, develop skills to navigate and get their questions answered so that they can become a better self-manager. And that's a very strong model, as we all know. On the right-hand side of the slide, we have a very different model, with a transitional care model, which will just say the role is deployed by a social worker. And again, the social worker meets the patient in the hospital to engage them and form a relationship, but using a little bit more of a fluid engagement strategy to either call or text or do a home visit within a couple days, to work with the patient in person or telephone and text, or as needed over 30 days, not adhering to a 4-part contact model, but really titrating per her discretion to what the patient really needs. The purpose of this type of a model is to really place the patient priorities first, to engage and be helpful, to understand that people's needs change over time, and so being more fluid than prescriptive is a strength of this model. So both models get results, but as you can imagine, each model is best deployed to a different patient population with different needs. So a classic example, let's see, do I have it on the next slide? Yeah, next slide, please. Yes, this is it. So, so a classic example is right here on the slide. We've got a care transitions model in a retirement community in Arizona. Is the first video. It's a 2-minute video. I really encourage you to watch it. From Sun Health, a very successful care transitions program. And the second video is from a more urban environment, actually inner city Oakland, California, where you can see this is a pharmacist doing outreach work into a home. And again, it's a 6-minute video, very compelling and effective care, a much more fluid model in terms of meeting patients' needs and taking a very holistic approach. So if you want to take a look at these 2 videos, I guarantee you will enjoy them and learn a lot from them. And you can then see how both transitional care models are effective, but what you really want to do is you want to match what you're doing to the needs of whoever your high-risk patients are. Next slide. So if there's one thing I've learned about delivering enhanced services, it's that we really need to do so by taking the whole person approach. A lot of us started off with a very disease-specific disease management approach in readmission reduction work, and most teams that I've met who have gotten the success that they wish to see move beyond a very rigorous disease management approach, and they are all characterized by saying something like this quote here on the slide, which is, our coaches, our nurses, our NPs, our social workers, whoever they are, our transitional care navigators are flexible, proactive, and persistent. They address all needs. Each of them has incredible interpersonal skills. And I think really, if I think about the successful programs that I've met and the programs that are working hard but not yet successful, this is one of the distinguishing factors, is being flexible and understanding that first and foremost, we need to meet the patient where they are and then figure out how to serve them and support them without needing to be readmitted. Next slide. So 2 inspiring examples for you, and then we'll turn to the 4th topic of the webinar. So these are both rural hospitals. They are both 2017 examples, meaning, you too can get these results within the course of our Readmission Refuel initiative. This was a hospital out of Mississippi. They had a transitional care nurse. The transitional care nurse was focused on about 5 different target populations. And they had 1 nurse. And the 1 nurse, she's running around looking for heart failure, COPD, pneumonia, and it happened to be for their community sickle cell as well. Okay, so those were data-informed targeting strategies. However, the size of the target population was no match for the resources, right, that they had available. So when I met them, they were banging their head against the wall saying, she's trying like the dickens to run around and get to everyone, but she can only do a little bit for all of the patients, and she misses half of them on a given day. So we said, well, then why try to keep doing that? If that's not working, let's rethink the strategy. And what we ended up doing is we ended up looking at the numbers. Remember, back to our data talk. And we looked at the numbers and we said, it looks like if we just focused in on heart failure, and that she would have 1 to 2 new patients per day, kind of a consistent load of 20 to 30 at a given time. And what she would do is a transitional model. She would have a brief encounter in the hospital, really just meant to be a meet and greet face to face. This is me. I'm going to be helping you over the next 30 days. And then she focused on telephonic care management over the 30 days, but it was in a very robust, holistic standpoint. She was dealing with affordability and social security checks and transportation and family dynamics and drinking and the whole thing, right? It wasn't just a heart failure management program. It was a transitional care nurse management program, much, much broader than heart failure. So it turned out that refocusing and letting her do her thing, letting her do her best work for the right size of a target population allowed them to see the change that they wanted to see over time. And this was, a great improvement for them, going from 12 heart failure readmissions per month to 3 heart failure readmissions per month. And that was with this one transitional care nurse and nothing more. So, well, I should add, they had the transitional care nurse was the active ingredient. She had a very important partner, as I noted on the screen, in the ED care manager, because the ED care manager would flag the heart failure patients in the emergency room, making it easier for the TOC nurse to pick up her target population patients. So great success coming out of Mississippi by matching not only the target population in need, but to the resource available, and then letting that resource do their job the best way they knew how. And then here we can see very clearly this hospital says, okay, well, transitional care nursing works. So now they're faced with the question, well, now do we need more transitional care nursing, or what should we do to spread it to the other target populations? But they're very happy now because they at least have a proof of concept that if we do this, it works. Next slide. A similar small size hospital had a 2-person team. And what I love, they have about an inpatient census of 20 per day, something like that. And what they did was they said, hey, any cardiac, pulmonary, or behavioral health, so they cast a very wide net, any cardiac, pulmonary, or behavioral health patient, we consider at high risk of readmission. They did limit their service area to like a 30 or 45-minute drive zone. And they identified 4 to 6 people per day as high risk of readmission in their hospital, which was, again, like a third of everyone in the hospital. They also did the brief meet and greet in the hospital just to establish that human connection, and they spent the majority of their time out doing home visits in the community. Interestingly, they used to decide between the nurse and the social worker, oh, that patient's, quote, more social, that patient's, quote, more medical, and they used to divide and conquer. But after a couple months of work, they realized that wasn't the way they wanted to keep doing it. So they go now do a nurse and social work visit together, each with their experience and perspective, and then they decide which of them will continue to follow the patient for 30 days. And they have found that that is a much stronger model for them than dividing up at the beginning. So I thought that was really interesting. As you can see, the great thing about this story is they have actually, and this is real, I've confirmed this, they have reduced their readmissions over that year by 50%. Amazing, amazing accomplishment with 2 very talented people, and that's it. There's no other program in the hospital that supports readmission reduction. Next slide. So hopefully you can see there are many ideas out there on, now that you know your data, you've thought about your new refreshed target population, you're going to connect to what the real root causes are. Once you identify root causes, then you want to just draw that connection between what brings our patients back, and so what should we do about it? And then we want to have you start testing those ideas. So plan and make improvements here in phase 2. Next slide. So we're going to remember and keep coming back to this maybe with your teams. Say, what's our aim? What does our data show? Who should we focus on? And thus what services we should deliver. Remember, I shared this with you before, most teams start in the reverse order. Most teams say, we're going to do a post-discharge follow-up phone call program. And they start at step 4. And they say, and we're going to call COPD patients. But we don't, but that's a potential mismatch right there. Because what if your COPD patients actually don't have a problem when you call them, but what happens is that they get breathless and anxious in the middle of the night and they call 911, and no amount of phone calls are going to help with that possibly, right? So we really want to understand what are we doing and why, and make sure that you're linking the service to the root cause. Next slide. So here are 4 questions that you can ask coming out of this webinar. Who's your target population? What are the root causes of their readmissions? What services would help to address those root causes? And how could you mobilize or provide those services? Could you do so, as some of our examples today, through existing hospital staff, thinking creatively? Or could you do so by engaging and linking to services, supports, agencies, providers in the community? Next slide. So as you get started, just to kind of get into some granular operational tips, and I know some of you might be doing this, but want to make sure that you have this kind of laid out for your consideration. I would recommend the following. Number 1 is identify your target population patients daily. So many of you have said, well, our target population is age over 80. Well, so how do you actually operationalize that? Do you have a tracker board? Do you have a flag? Do you run a list of your census and have somebody highlight all of the patients in-house that are over age 80 or are 51 to 64 or over 66, whatever your criteria are? If you've said that your target population is age over 80 or age 51 to 64 or all heart failure, AMI, pneumonia, COPD, how do you identify those patients on a consistent, reliable, daily basis? And how many people per day is that? Just like my example with the heart failure transitional care nurse and the nurse social work team, the heart failure TOC nurse knew that she had an average of 1 to 2 patients per day. That's actually who showed up, not how many she was able to enroll. It was 1 to 2 patients per day in the target pop. So too with the nurses, they were getting 4 to 6. Nurse social work team, they got 4 to 6 new patients per day in the target pop. So you want to measure it based on who meets your criteria on a daily basis. And then once you have a good system in place to identify those patients that meet your criteria, you want to get to the bedside and talk to them about why they came back to the hospital. Practice the readmission interview. Do several yourself. Once you do several and you feel comfortable, teach others on how to do it and why to do it. And then very importantly, it will strengthen your work if you bring these stories back to your readmission team meetings and just start every meeting or incorporate into every meeting 1 or 2 recent readmission interview stories very briefly. Oh, next slide. The next recommendation is once you start getting in the habit of identifying your high-risk patients, getting to the bedside and talking to them about their readmissions if they've been readmitted, develop a working list of those root causes. And even start this week. interview one patient and start your list, whatever that root cause is. Add to it over time. Don't wait for it to be perfect. Usually once you do 8 or 10 of these, you start to get to a convergence of themes anyway. Number 4 would then be to do the work that we discussed in the main part of the webinar today, which is link the root causes to the services and supports that could address and avoid a readmission for people with that root cause. So you can test the tools that we reviewed today and keep it simple to start. The program I told you out of Alabama, they wanted to start with kind of I think it was even 5 or 8 root causes all at once. And it was getting overwhelming, and there was a lot of debate in the committee as to exactly what to do and when and how and what to start with, etc. So we recommended that they just start with 1. And that's when they chose polypharmacy. And that's when they connected the dot. What do we do for polypharmacy patients? Oh, they then asked the director of pharmacy. That led to his willingness to engage. And then they developed a very robust problem response solution based on polypharmacy. And then they moved to the next thing, which for them was transportation issues. And they developed a plan for that. So take it one at a time and build it as you go. And that's, I think, the way you can really develop something that's going to work for you and your resources. Next slide. Finally, implement. So test and learn. So once you identify, let's just say polypharmacy, going with this example I shared with you. Once you identify that your pharmacist is willing to work with your patients with polypharmacy, have them get started. No reason we can't start tomorrow. The next patient with polypharmacy. Hey, Joe, can you go meet with the patient in room 22, right? And see, and then get some experience. How did it go? Do you feel like you were able to be helpful? Can you do it again the next day? And just test as you go with your target population patients. Importantly, it's really important to then go ahead and measure on a weekly basis the following 3 things. How many target population patients were there? So again, going back to your own survey data, how many people over age 80 were admitted this week? And then let's say if they're over age 80, you're going to make sure they have transitional care. How many of those patients were offered transitional care, and how many actually received transitional care? And those 3 data points will help you implement and improve on a week-to-week, month-to-month basis. And that's the final step here, which is using your experience, getting your feet wet, testing your idea, measuring it on a weekly basis. You will incrementally improve your approach to achieve success. Next slide. So to summarize our 4 points today, a big emphasis on root causes of readmissions, identify readmission risks and the post-discharge needs of your patients, make sure you develop enhanced services to meet those needs, and plan and make improvements. And we're really looking forward to the improvements that you're going to make in the upcoming month of March. Next slide. So with that, I've seen the chat flash up a little bit. So let's see. There's some questions here. I'll just field 1 or 2 before I turn it back over to Kate to close out. Nancy asked a question, what's the reimbursement for the home visits by the social work and transitional care nurse? So most often, Nancy, these days, transitional care is funded by the hospital, if you will. So the pharmacist was an FTE of the hospital, the respiratory therapist, FTE already of the hospital. The transitional care nurse from Mississippi, she was already a staff nurse that was repurposed to be a transitional care nurse. So she was already a hospital FTE. And in the last case of the social worker and the nurse team, they were, again, employed by the hospital to do transitional care work. That small hospital wasn't critical access. They were a small community hospital, and they were getting hammered by readmission penalties. So, so that's kind of where it made sense for the hospital to do that. So thanks for the question. So with that, I think I will turn it back over to Kate to close us out from the webinar today.
Very good. Thank you, Dr. Boutwell. I know that we are approaching 12:30 in time. I really appreciate all of your attendance today and commitment to this project. Just a couple reminders on next steps as we move forward from today. Please do share your content from today with your team. We understand that at times it doesn't work for your whole team to attend the webinars, but remember, these are recorded and transcribed and will be available to you on Hinnovation. I'll also be sending out an email to your organization's Refuel project lead in the next couple days with that link directly. And secondly, get to action here. We really want you to use this information, plan and start making your improvements within your identified target population. And certainly really encourage you, as you did in phase 1, to reach out to our team for coaching if needed. Go ahead, if you want to pre-plan a day to come in for us to come on site and work on some process improvement, to work through how to come up with an enhanced service or maybe make that come to life. We'd be happy to work with you. So send me those email requests and we'll get that coaching on the calendar. Once again, just a reminder to please do register for the phase 3 webinar on April 11th. Thank you so much for your participation today. We look forward to seeing you in April. Thanks.